Hello, this is Lee Myers, and I am going to present my capstone project, Pediatric Mild Traumatic Brain Injury in Sports, an Educational Intervention for Nurse Practitioners. Hello, my name is Lee Myers, and I'm a Doctorate of Nurse Practice graduate student at the University of Massachusetts Amherst. For my capstone project, I am introducing a toolkit for nurse practitioners and other providers that will disseminate the American Academy of Pediatrics and the Centers for Disease Control and Prevention's newest evidence-based practice guidelines on the diagnosis and management of mild traumatic brain injury among children, issued September 4th, 2018. A research toolkit is useful for this project as it is meant to provide evidence-based care that promotes quality health outcomes for individuals, families, communities, and healthcare systems. The CDC recommends using the term mild traumatic brain injury, mTBI, in place of the term concussion moving forward so there is consistency and no misinterpretation across stakeholders. Evidence suggests that there is a variability in provider care, experience, and training, coupled with an explosion of previously published consensus statements and no formal United States guidelines, has led to uncertainty and inconsistency in the management of these injuries. The CDC guidelines offer 19 sets of clinical recommendations that cover diagnosis, prognosis, management, and treatment. The guideline is applicable to healthcare providers in all practice settings and highlights specific actions healthcare providers can take to help youth athletes and their parents and caregivers cope. These include 5 practice-changing recommendations. Number 1, do not routinely image pediatric patients to diagnose mTBI. Clinical evaluation of the child with possible mTBI includes balancing the likelihood of possible tragic complications of a more severe injury against the risks associated with head CT, such as radiation exposure and concomitant sedation imaging. If the provider suspects intracranial injury, then head CT is a preferred diagnostic tool in acute care settings, and the family should be counseled as such. Number 2, use validated age-appropriate symptom scales or decision rules to diagnose mTBI. Examples of validated scales include, but aren't limited to, the Post-Concussion Symptom Scale, Health and Behavior Inventory, Post-Concussion Symptom Inventory, and the Acute Concussion Evaluation Form offered at the CDC website and Office and Emergency Department versions. Number 3, assess for risk factors for prolonged recovery, including history of mTBI or other brain injury, severe symptom presentation immediately after the injury, and personal characteristics and family history, such as learning difficulties and family and social stressors, because all of these can impact recovery and outcomes. This is why it is important to have a pre-participation physical on file with premorbid conditions clearly documented in the record. Number 4, provide patients and their families with instructions on returning to activity customized to their symptoms. Number 5, lastly, counsel patients and their parents, caregivers to return gradually to non-sports activity after no more than 2 to 3 days of rest. The provider should offer clear instructions, preferably verbal and written. The CDC offers free resources at their Heads Up Clinician website and are easily downloadable. According to the CDC, mTBI occurs in approximately 3.8 million people annually, with those numbers rising among children and adolescents, putting this population at risk for a syndrome which can last weeks to months and affects cognitive function, memory, and sleep, and can be physically exhausting. As the number of emergency department visits for mTBI increases, so does the demand for primary care providers competent in the evaluation and management of mTBI during both the initial presentation and clinical follow-up. The CDC 2018 guidelines define mTBI as an acute brain injury resulting from mechanical energy to the head from external physical forces. It is defined as mild by a Glasgow Coma Scale score of 13 to 15, measured at approximately 30 minutes after the injury. The pediatric emergency care definition defines mTBI as an injury resulting from either a direct blow to the head, face, or neck, or other part of the body with an impulsive force transmitted to the head. The development of short-lived impairment in neurological function that resolves spontaneously, though symptoms and signs may evolve over a number of minutes to hours. Neuropathological changes from the acute symptoms largely reflect a functional disturbance rather than a structural injury, and as such, no abnormality is seen on standard neuroimaging studies. There are a range of clinical signs and symptoms that may or may not involve loss of consciousness and typically follows a sequential course, however, in some cases may be prolonged. There are 4 domains of signs and symptoms, including the physical, cognitive, emotional, and sleep. Post-concussion syndrome is a common sequelae of mild traumatic brain injury. It involves a constellation of symptoms that includes headache, dizziness, neuropsychiatric symptoms, cognitive impairment, and 50% of patients report personality change, irritability, anxiety, and depression after mTBI. Symptoms occur within the first 7 to 10 days and go away within 3 months. Sometimes they can persist for a year or more. Second impact syndrome is a fatal complication of mild head injury. The syndrome can result in devastating consequences such as collapse, death, permanent neurologic damage, respiratory failure, and loss of consciousness. Since second impact syndrome can result from a second injury before complete symptom resolution from the initial mTBI, it is imperative for practitioners to ensure adequate recovery and prevent the athlete from returning to play prematurely. Furthermore, repetitive mTBIs over time have been linked to conditions such as depression, mild cognitive impairment, prolonged recovery from future mTBIs, and potentially chronic traumatic encephalopathy. Evaluation of an acute injury should include a comprehensive history, determination of the mechanism of injury, mental status testing, and a detailed neurologic assessment. Red flag signs and symptoms such as prolonged loss of consciousness, persistent alterations in mental status, and abnormal findings on a neurologic examination should prompt urgent neuroimaging and with referral to the emergency department and possibly neurosurgical evaluation. The acute concussion evaluation form may be helpful for follow-up of patients in the office setting to do serial evaluations. The practitioner should identify and tailor treatment plans and referrals. For example, for the patients with acutely worsening headache, consider neuroimaging. For the patients with chronic headache and prescribed non-opiate analgesia, such as ibuprofen and Tylenol, consider a multidisciplinary evaluation from a neurologist. For vestibular ocular dysfunction, consider vestibular rehabilitation with a physical therapist for balance problems and dizziness. For worsening sleep problems, consider sleep hygiene education and referral to a sleep specialist if symptoms do not resolve. If the patient has cognitive impairment, the treatment is directed at the etiology and a neuropsychological evaluation is helpful. For emotional dysfunction, consider psychotherapeutic evaluation and treatment. The guidelines say to provide anticipatory guidance and reassurance of the warning signs that injury may be more serious, the typical recovery course, how to prevent further injury, the gradual reintroduction of activity that does not worsen symptoms, offer clear instructions, preferably verbal and written, on return to activity, including school and sports, customized to the patient's symptoms. After a few days of rest, 2 to 3, begin light activity and then gradually reintroduce regular activities not inclusive of sports that do not significantly worsen symptoms. assess school-related needs, and monitor progress in collaboration with parents and school professionals. Once back to regular non-sports activities, including school, the patient can begin return to sports using a standard progression with a gradual increased level of physical exertion. No return to contact sports activity until symptom-free with exertion, including without the use of pain medication. The CDC training offers 2 CEUs and may be mandatory by your state to provide medical clearance. The return to play protocol uses a stepwise approach. It is important for an athlete's parents and coaches to monitor for concussion symptoms after each day's return to play progression activity. An athlete should only move to the next step if they do not have any new symptoms at the current step. If an athlete's symptoms come back or he or she gets new symptoms, this is a sign that the athlete is pushing too hard. The athlete should stop, and they would need to go back a step. Baseline, the athlete needs to have completed physical and cognitive rest and not be experiencing concussion symptoms for a minimum of 24 hours. Keep in mind, the younger the athlete, the more conservative the treatment. Step 1, the athlete is back to regular activities such as schools, and the athlete has the green light from their provider to begin the return to play process. It starts with a few days of rest and is followed by light activities such as short walks and moderate activities such as riding a stationary bike that do not worsen symptoms. Step 2 is light aerobic activity. 5 to 10 minutes on an exercise bike, for example, walking or light jogging, no weightlifting at this point. Step 3 is moderate activity, and you continue with activities to increase an athlete's heart rate with body or head movement. Brief running, moderate intensity stationary biking, moderate intensity weightlifting, and less time and or less weight from their typical routine. Step 4 is heavy non-contact activity. Step 5 is the patient is allowed to practice and have full contact in a controlled environment. Step 6, the youth athlete may return to competition. If the youth athlete becomes symptomatic at any point during any step, he reverts back to the previous step. Primary and secondary prevention counseling. It's helpful to do primary and secondary prevention counseling during the physical exams and follow-ups. Primary prevention of some injuries may be possible with modification and enforcement of the rules in fair play. Helmets, both hard, football, lacrosse, and hockey, and soft, soccer and rugby, are best suited to prevent impact injuries such as fractures, bleedings, lacerations, but have not been shown to reduce the incidence and severity of concussions. There is no current evidence that mouth guards can reduce the severity of or prevent concussions. Secondary prevention may be possible by appropriate return to play management. In recent years, there have been a series of varying mTBI laws passed throughout the United States, modeled after the landmark Washington State Zachary Lystead law. These laws have been enacted to improve recognition and management of sports-related mTBI with 3 common foundational principles that include recognition, education, sports removal, and return to play. The laws are also explicit that healthcare providers participate in required trainings to diagnose and manage mTBI and youth sports and provide medical clearance. I would like to thank all of you for your participation in this educational intervention. It is my hope that providers and practitioners that may be watching this presentation will have the resources, knowledge, and confidence to make evidence-based clinical decisions and have improved management strategies when caring for the pediatric athlete with an mTBI in their respective practice settings. I recommend that you take the post-test for the activity, and please review the toolkit and follow the provided link to the CDC website to obtain 2 CEUs from the new learning modules created in January 2019. There is abundance of resources for you to utilize on their website, including age-specific grading tools and downloadable educational material, such as handouts for parents and athletes.